Good morning, good morning, good morning. It's still got a couple of minutes before we get started formally. I see there's about 8 of you online or not. This is kind of exciting. We've got people from Japan to Europe, plus that small country called America in between, logging in to check this out. And my name is Dr. Gordon Elder. I'm the third director of the original Blair Chiropractic Clinic in Lubbock, Texas. And I was asked by the Blair Club at Sherman College, where I teach a couple of times a year, if I would do something like this, about an hour, just go through and do an analysis. And I thought, well, that's something that could be regular, so we'll see how long it lasts. But I just pick a CT scan, usually from the new patient from the previous week, and anonymize it. And then we go through it. So we're going to keep doing this until interest wanes, or I don't know, until I become rich and famous. Kind of hard to do that when I'm doing it at no charge, which is my pleasure. But you can see on the screen in front of you, I believe, the 3D version of a 37-year-old male. Came into my office last week. And this is what I look at first, or at least some point in the analysis process. And this is more just to give me an overview. I don't do my analysis off this, although it can be a valuable part of the analysis. Really, it's more just to get an overview so that I know where to look when I'm looking at the what's called the NPR views, or the slices. And we can see he's got a little bit long styloid processes, both sides, right more than left. It's not severe. I mean, it's not super long, but they're a little bit long. They're long enough that if the atlas has moved forward enough, that the structures in between might be compressed a little bit, which, that's pretty narrow there, but that could be normal for them as well. So that's something else we have to consider, is that normal is not the textbook. Pretty close, not much room in there, but it might be just the way he's made. Like looking down the top here, see if we can get any hints. Nothing really major. It looks like maybe C1 is rotated posterior on C2 a little bit on the right side. Doesn't seem to be quite as smooth going down that central canal, but hard to say. Hard to say. Nothing really obvious on that. I like looking at the jaw. The jaw and the upper neck really affect each other a lot. Sometimes somebody with a jaw or a dental problem can keep going back out of alignment because of the stress that puts in the upper neck. Sometimes a jaw problem is actually a neck problem, so it goes both ways, obviously. Anyway, so that's the first thing I look at. Now, a couple of things about this hour. This is not a pathology tutorial, so this is assuming that you are looking at everything for pathology, or sending it out to a radiologist and getting a path report, so that you don't miss anything that might be small. Also, this is not a tutorial for a particular program. There's a lot of different cone beam programs you can use out there. The one that is the most common, I believe, is the CareStream 3D. It's a free program. It works well, and I like it for Windows. However, I use a Mac, and so I wanted to find a Mac version that worked well. And the one that I'm the most comfortable with is Horos, Horos. And it's free, or almost free. I think maybe you have to pay a couple of bucks to get the wording off of it that it's not to be used for diagnosis, and then it's acceptable. But it was a while ago that I did that, so I don't remember particularly. So this is not really a tutorial on how to use a program. There are tutorials out there you can find on YouTube, or with Jake Hallowell's with his module that you can find on the Blair website. His is all CareStream 3D. I'm happy to answer questions on how I do things with this privately, but that's not what this particularly is for. So right now, let's get started. First thing I do is look at this. I don't see anything super super big, super wrong. I mean, it looks like maybe there's some misalignments here between C2 and 3 and C3 and 4. Obviously, the spinous processes are fairly well lined up, but they can be bent, so we don't really want to take those into account anyway. The big thing with the Blair technique, of course, is the fact that everybody's made a little bit different on the left and the right and from each other. So we can have some basic symmetry, but when it comes down to the small joints, an asymmetry there can really affect how you analyze the upper neck if you're not taking that into account. So the question he ran into was, well, how do I take that into account? And then he realized he could actually look at the joints themselves to see if they were lined up. But not every part of every joint lines up perfectly with the other side. So in other words, the occiput and C1, the two condyles, don't always line up in every area. Assuming juxtaposition, assuming everything is perfect in a perfectly aligned spine, not every area is going to be lined up properly, but there are some that should be. And so that's what he decided, figured out how to find. So that's what we're going to do. So first thing we do, we look at that 3D version, see if there's anything that we want to make sure we're looking at really close. When we go to the NPR version, we're going to stop the share there for a moment and go to the, there it is, the NPR version. So this is called multiplanar resolution, NPR for short. You've got your 3 axes, and you'll notice that my patient is not in the center. What's going on with that? Am I just sloppy in taking my pictures? We want to make sure, just like when we're taking a spinograph is an x-ray, but it's taken weight bearing and it's taking in the patient's normal habitual head carriage, body carriage, posture. Same thing when we use a cone beam. Now my cone beam is seated, so I can't move the patient and keep them in their same position, except up and down vertically, to get them in the right spot. So we just make sure that as we put them in the seat and we get them in the right position, we have them close their eyes, turn their head left to right 3 times and see where they come back at the center, and make sure that they're always coming back to the same spot or near the same spot. And then we take the picture. So sometimes many people will look a lot worse than this. You'll see a head tilt, you see a head rotation, and it looks like I just threw them in the machine and took a picture pretty sloppily. But what it is their natural, normal, or maybe normal isn't the right word if they're subluxated, but their habitual head carriage. So what we're going to do, I'm going to make sure that I can see if there's any questions or chat comments that you guys might bring up over time. But so this, I just pulled it up. I made sure that left was on the left, right was on the right. And this is it pulls it up at the smallest slice interval possible. So my particular machine, it runs the way I have it set. It runs these slices at 0.3 millimeters. 0.3 millimeters is really, according to the radiologist, a little bit too small to look at things really well. What they suggest is going up to 3 millimeters. So that kind of begs the question, well, why do we even have 0.3? And it does give us a better resolution at the 3 millimeter mark. It does help. So let's, I'm actually going to change this to start off with to 10 millimeters. When we're analyzing joints, of course, it was based on plain film x-ray, right? And so we have Dr. Blair's procedure that he tested and tested and retested and tweaked and retested and then finally taught and mastered, and that was based on plain film x-ray. Well, there's only a certain amount of things you can do with a plain film x-ray, and of course that's a full thickness slice, as you will. But where you can put the tube and those kinds of things, he was limited. So there's some things that we can do more with cone beam other than just rotating it differently and seeing things differently. But the problem is not all of it has been 100% tested to see if it's as accurate or if we can change some things based on Dr. Blair's principles using cone beam. So there's going to be some things that are a little bit different if you're familiar with the plain film or digital x-ray analysis for Blair, but it's primarily the same, and we're going to walk through it. The first thing we need to do is we need to know what we're going to be measuring to. So we need to kind of center everything. Now, Dr. Blair would measure angles to the ground, in other words, at the bottom of the film. But of course, setting up the patient in the X-ray machine, he would be very careful that they were in their normal head carriage, but he would make sure that they were centered at just the right spot so they weren't rotated, or unless he wanted them to be rotated. So in this sense, we can see that in the central picture, we're off center. Everything else actually on this particular patient, as I said before, looks pretty good. We're not seeing much rotation. One thing I have noticed is that the face and the calvarium, the facial bones and the calvarium, can be offset, can be angled differently. So if you center to the hard palate, for example, in this view, and then you look at back here, it can be off center. So this gentleman, fairly symmetrical as far as that goes. So what I'm going to do is I'm going to line up with his ear canals, and in both in the axial and transverse plane, and make sure that we're fairly central. Everything looks pretty good, so I'm not having to manipulate this one at all. Now with this particular, I want to be able to come back to this point. So with this particular program, if I make a mark, it disappears as soon as I move, unless it's these dots. So I'm going to go ahead and put these dots here, just so that when I come back in order to take measurements and be always consistent, I can come back to the same place. Okay, now what I'm going to do, make sure these are centered on the others. There is a certain amount of learning that you have to do with each program. So if you're brand new at this and you get a cone beam, and somebody's cone beam, and you're trying to figure it out, it can take that first few times you use the analysis and you're using that program, it can really take a long time, just because you have to learn the program, even if you're already familiar with the analysis. Okay, so if I just click on all of those, now we can see everything is pretty centered. I'll be able to come back to this position. Now, the first thing that Dr. Blair would do would be to look at the base posterior, because in order to analyze the actual, or to measure and have accurate measurements for the adjusting and for knowing how to shoot his next x-rays, he had to know how the condyles were shaped. Now, condyles are ellipsoidal joints. I'm just going to come right down here. You see, I'm already going to start changing things. So when I start measuring, I have to be careful, because I'm going to move this along the atlas plane line. Now, Dr. Blair couldn't do that for most patients because the tube would be too close to the patient. He would run into the patient. So he ended up coming in about 45 degrees, and he would tilt the film bucky so that it was 90 degrees to the tube, but he would tilt the whole thing so that he was coming in at a 45 to 90 degrees to the patient. But we can actually come in right here, which makes it a lot clearer to see the atlas. Notice here again, we can see that the styloid processes are pretty close to the transverse process, so we're not going to worry about that right now. All right, so we have our atlas. All we did was we tilted on this plane. So when I measure the convergence angles, we didn't change this at all. As soon as you start twisting on more than one plane, your measurements all go out the window. So we have to make sure that we always go back to either only have moved one plane and then not measure that one, but measuring basically back to square. Go back to the square patient and measure from there. A couple things I'm noticing here. I'm going to get rid of the crosshairs here for a moment. So there is an increased space here on either side of the dens. It could mean that the atlas is unstable and has actually moved off to the right. But when you look down here at the lateral margins, we can see that that did not happen. So he actually was probably made that way, or there might be some rotation. Now, if we look in here where the joint, let me get rid of those. they seem to be lined up fairly well, maybe a little bit off, but I don't think we're looking at a case of instability or ligament damage. At least I'm not thinking that yet, but it's something I take note of. So how are we going to analyze this? First, we need to find the long axis of these two ellipsoidal joints. So Dr. Blair's process was such. First, he would outline the joints, but that was because he was looking at an x-ray and he had lots of things over and under. We're at 10 millimeters. We're pretty much, let's see, on this side, I'm going to bring it up just a little bit so that we've got the whole joint within our framework, okay? And we can see the notches here between the anterior arch and the lateral mass, and we can see where the posterior arch meets the lateral mass. So what we're going to do is we'll put a dot here, draw a straight line 90 degree out, and then 90 degree out. Now the way I do that with this particular program is dot there, and out here. All right, and that's about the edge of the lateral mass. Now we're looking at the edge of the lateral mass, not the actual joint itself. Partly, I believe, because what I've been told is that Dr. Blair was developing a system where he could using things he could consistently see on every patient, or at least almost every patient. Whereas a lot of times you can't see the joint itself. You can certainly see the lateral mass. So we've got a 90 degree there. Boom. We're going to come out here. Come out here to the edge of the lateral mass, 90 degrees, boom. Okay, now what we're going to do is we're going to bisect these two lines here and then draw a line through it. And that's the long axis. That's the calculated long axis, not the actual long axis of the ellipsoidal joint. Now that we have cone beam, we may be able to develop a system that actually finds that. The question then is, do we need to? Which gets into a whole different subject. That's a different lecture. But what we're going to do is we're going to bisect those. Now you can do it by eye, but I would say that in the beginning, go ahead and actually measure. So I'm going to measure that one. We got about a 7.2, pretty close to 7, so 7.5. I'm going to say 3.25. I'm going to come in here now. I'm going to offset this line just a little bit so I can see it. If I have it right on top with this particular program, and then I go away, see how hard that gets to see. This one actually, I can see mostly, so. Oh, now we're going to come over here, measure that 1.1, so what, 5.5 is about the center of 11. Okay. All right, so now I found the center of those two lines. I'm going to run a line through those and measure it to this. Now remember, I've only rotated on one axis. It did not change this line. This line just went up and down, which from this view means it's still in the same spot. So I can measure to that line to get my angle. But again, because things move around, and if I make a mistake, I want to be able to come back to this without having to redo it. With this program, I'm just going to put some dots right here that will kind of stay permanently or until I really want to get rid of them. And then I can come back up here. And he's got a fairly steep or large convergence angle. Typical convergence angles for most people is 18 to 33 degrees. This one is 40.6, so about 41 degrees. That's pretty big. Let's just leave that there. We'll kind of take note of that. Let's go ahead and get one here. We got the notch. We got where they meet there. Now, Dr. Blair actually originally, this line back here was where the foramen magnum crossed that line. He said you could use this one, but he preferred the other one. The problem with cone beams is that the thicker the slice you get, the less definition. So it starts to get really hard to see a lot of these things. And most doctors, even sometimes on the plain film, will use this posterior arch. Now, technically, I think we really should study that and come up with hey, this, it's about the same this many times, and does it really affect the overall goal or not? I don't think it will find that it does, but there we go. And you've already seen the process, so I'm just gonna eyeball it for speed. That was not right in the center. We'll come back and fix that in a minute. Good. Yeah. Problem with fixing that is now I've got to do all kinds of fun things. Pretty close? Okay. Let's bring this back up on and measure that angle. So this is what's called the convergence angle. It's how the AO joints converge towards the anterior. And we're going to use it to be able to look at the whether these joints are lined up or not. Now, what Dr. Blair found out, originally he just thought maybe it was a mirror image all the way around, but what he realized is that lateral margin, if you're looking parallel to this line, so it's not pure lateral to the patient, but anterolateral, but this lateral margin here is where the body is most likely going to be lined up when everything is perfect. If the person is in alignment, that's where it's lined up. So if they're not in alignment, if they're subluxated, that's where you're going to find the misalignment. Okay, so we got a 26 on this side. That's certainly more within normal. We've got a 40.6. I would write this down at this point, take a screenshot so I can show the patient later or look back at it later and see how I did it, see if I made any mistakes, if I'm having problems. But at this point, what we're going to do is we're going to get rid of this rotation so that we can come back and measure these laterally. We need to measure a couple of different things off those joints, and we also need to analyze them and see if they're lined up or not. So let's get back up here. Let's go back to square. Okay, we're going to move that. Good. And we're going to rotate. All right, pretty close to square, square, square. Good. All right, now we're going to go back down and say I've got those dots there. Some programs you'd still have the lines. So now I'm going to come over here and put my center line right through that convergence angle. Good. I'm way too far forward. I don't want to know what the joint looks like up here. I want to know what it looks like back here. So I can increase the angle. Increase the size of the slice. Usually, it seems like most joints are about 20 millimeters, 15 to 25, typically 20. But I'm going to come back here. Now, what I'm going to do before because there's some things I can do to make this a little clearer out here. This lateral margin is where we want to see, but it's not super clear right now. Obviously, I can get rid of this, but we're going to keep that there for a minute. You notice we went back to square, went to something and only rotated on one way. So now I can't measure in here the convergence angles because my crosshairs are all messed up. But now we can actually measure the slope angle and the convexity angle. Now the convexity is the whole wheel shape of the joint, but we want the posterior 1/3. Why? Because some of the adjustments are required, not for the analysis of the x-ray. So this is not necessarily for analysis, but later on, if you're doing a Blair adjustment, you want to know how the joint is shaped. Oh, that was already there. We're going to come in here. Now it's a little bit hard to see, but there's the joint. Now, I don't know if that long line is, I got pretty close, but so now I'm lining it up with what I wanted to measure it to, which in the case of this particular x-ray is the ground or the bottom of the film, if you're thinking in plain film terms. Okay, we've got a 19, fairly kind of shallow slope there. Let's go look at the convexity. Now, when we're doing this with plain film, You're just getting this view over here, and you can see the convexity of the other side. Here, let me finish this up before I start playing with that. So that's one thing that's a little bit different here, is we can actually measure the convexity, the pure convexity, as opposed to kind of an ersatz convexity. All right, I'll take a picture, write that down. But if we increase this to 20 millimeters, all right, bring it back in center. All right, now we're starting to see some joint over there, but not much. But you can see we started to lose some definition in there. We can see the whole joint, and we might think it's gone anterior because of that lateral margin, and perhaps it has. But we can see the convexity of the left side over here, and we can measure that. Now, it's not the pure convexity because we're not coming in 90 degrees to the joint, but it's useful. It's good enough for doing an adjustment. It gets you in the ballpark, so to speak. All right, so we've not analyzed, but we've measured the right. Now I'm going to go on to analyzing this joint, because I've already shown you, you just do the same thing for this side to get those two measurements. But let's analyze this. What can we do with a cone beam to make this a little bit clearer? Well, there's a couple of things. I'm going to take it back down to 10. I'm going to line this up with the convexity, tangential to wherever my central ray is, and through the slope. I'm not quite sure what happened there, but it looks like everything's okay. Now I'm getting a better idea of that lateral margin of the joint. And the most lateral margin is out here compared to, let's rotate it back towards, there we go. We're pretty close to the most lateral, but still not real clear. Well, I can come over here, and now I can line this up tangential to, look how much that cleared up right there. Okay, and look, we have some extra lip out here that's not actually part of the joint. So when we look at the skull coming down and the atlas coming up, we could have been fooled by this part here if we hadn't have cleared that up. Okay, we're thinking, oh, that's the lateral margin of the joint. No, it's not. It is the lateral margin of the lateral mass, but it's not the lateral margin of the joint. We're actually looking pretty close here now. So I can move kind of back and forth and see what happens. And if we start going too far back, we're going to start seeing some misalignment. Same thing happens if we go too far forward, which I would need to change this. It starts to not be quite as clear or as accurate. So we're going to come back here. Boom. We're going to say, hey, the right side's even. Now, sometimes I'll move it around a little bit and see if that'll help. I may move this up and down a little bit, see if that'll help. In this case, what I prefer to do is I prefer to analyze these. Since I know where I need to look, I prefer to analyze these at the 5 to 3 millimeter mark. So let's bring this. Let's make sure we're still lined up here. Quite. Okay, so this part isn't the joint. This is the lateral mass way out here. Here's the joint. So coming in, I'm going to put that all right there. We're going to move this. Boom. And I don't know how clear it's coming across to your joint, but we're still pretty lined up. We've got the joint ending right here on the atlas and here on the condyle. Okay, now things are unclear or something. Remember, you guys can ask questions or use the chat function to have me clarify something. Okay, so pretty clear on that side. Let's go look at the other one. Now, we would have already measured. Now that we've been turning everything around, if we try to measure this one over here, we don't have anything to measure it to. So we would, if I had done all of that ahead of time, we would have had to go back to square and come back. So that's why I do all the measurements first, and then I go analyze, because that's one thing I don't like about this particular program, is if I am not 100% on the grabbing. Good. Good. Okay. We didn't waste too much time. So I'm going to line it up. We know that I need to move back here somewhere. Now this gentleman, I noticed this last week, and you're just going to have, everybody's going to have something a little bit odd. Sometimes things are just super easy, but look at the shape of this joint. I mean, it looks like there's the front there, and then you've got this huge wedge, but it seems fairly, same. It's almost like there's a malformation on the anterior portion of his joint. However, it can become fairly clear if we move back until we find the best position. So now we have an overlap. In other words, the anterolateral margin of C1 parallel to the convergence angle at its most distal spot is definitely lateral to the lateral margin of the occiput. So we have an overlap. This gentleman is an ASL in the Blair parlance. In other words, the atlas has gone anterior, superior, and left. And we can adjust that from the left transverse process. We can adjust that from the right transverse process. We can also adjust that from the right posterior arch. Sounds strange, I know. That's part of the Blair lectures. So, but there. Really pretty. I mean, we can see that the joint actually ends here. Was this an injury from a childhood? I don't know. But the joint really does start here at this point, and we can see that there's a large overlap. So we'll be adjusting him, or I have adjusted him already, ASL, and he had some remarkable results. His primary complaint was anxiety. He had a lot of other stuff, dizziness and headaches and neck pain, but the anxiety was crippling his life. As you can imagine, severe anxiety. Next day, it was gone. Now, I haven't seen him since. I'll see him again this week. He's coming from a long ways away. So we're not seeing him as often as I would like. I did get him to stay the night and come back the next morning, but we'll see how he does. It'll probably go up and down for a little bit. Okay, so now I have analyzed the atlas. Some doctors, that's all they adjust. That's all they're going to look at. But we are going to do our due diligence, and we're going to look at everything else as well. So I'm going to come back here. Let's go back to 3 millimeters. 3 to 5 is where I like to kind of live. And we're going to look at a few other things. One thing I do that is not Blair, that you might be interested in, is I like looking at the rotation of C1 on C2. Often I will take that into account when I'm deciding where to adjust something. So what needs to be adjusted? You look at your neurological tests, how things are made and how they're misaligned. You look at the CT scan. So for the atlas, you're looking at the AO joint. But if the AA joint is misaligned and you have options on how to adjust the AO joint, then this might inform you on which one is going to be better. What's going to help correct this as well. Now, I'm not saying, let's get over here. I can do the same thing. We're going to line up. There, just okay. We're not taking measurements at the moment, so we can skew the view. Backside edge is what I typically look at. I'm not sure what other people do because that's the part that's in the neural canal. So how is that lined up with the superior articulating facet of C2? Looks a little anterior. And when we go medial, looks fairly lined up. But the lateral, out laterally is where you're going to see a greater evidence of rotation. So I might just mark that down. I'll keep that in mind. Move across to the other side. Again, line up my crosshairs and take a look. That looks pretty good. Let's move back and forth a little bit. Okay, a little anteriority maybe at the house, but overall, compared to some of the ones I've seen where, a quarter of the joint is hanging off somewhere, this is not large. I doubt that it's creating a problem. Okay, so let's continue with the Blair analysis and let's look at the lower cervicals. Now, I'm going to want to measure these, but now I've skewed everything around. So let's analyze them first. We can come back and measure them later. What I'm going to do is I'm going to come right in here. So we're looking at C2-3 joint on the right. Dr. Blair said the anterior margin is where you want to look. All the other margins wear differently, and so the joints can not be a mirror image. So if you can see it, you want to see the anterior margin. This one seems fairly clear. Let's just move back and forth a little bit. Now we're going medial. We're going lateral. Now, I'm not measuring it. I want to see that these are ending at the same spot, but I'm going to draw a 90-degree angle to this joint. Now, I don't typically do this. We eyeball it, but if you want, you can. Say, all right, there's this joint. And we go to 90 degrees, and that joint is ending pretty much at 90 degrees. It's not 90 degrees to the ground. It's 90 degrees to the other joint surface. Okay. Looks pretty good. Now, I can do a lot of stuff here. I can rotate around, if I'm not certain. The laterals, when we're looking at plain film and digital film, even, the laterals are often the most difficult ones to, even if you've done everything right, sometimes the laterals are the most difficult to analyze. And the reason is because the pedicle, the calcified margin of the pedicle here, the cortex, will often run into the thickened cortex of the joint itself. There won't be a little bump there to tell you where it ends. There won't be a change in the thickness. It'll look like a straight line or just not be super clear. So it is nicer with cone beam, and we can bounce back and forth between the 3D and this. A 3D, you can't really see the thickness unless you start slicing things. But we're gonna look there. We're gonna say, hey, C2 on 3 is lined up. If it wasn't, now let's back up. If you can't see this margin, Dr. Blair came up with about 5 other ways to kind of look at all the evidence and see if you could figure out. If you were pretty sure C2 on C3 was misaligned and you wanted to know what direction, or to really double check, then but you couldn't see the anterior margin, then what you would do is you would look for a couple of things. You could look at the posterior margin. It often is not lined up. So a lot of these things these are not hard and fast rules. So you can look at the posterior margin, see what it's doing. This one looks a little, maybe a hair anterior, mostly lined up. You can look at the joint. Is it wedged? It's wedged anterior, which could indicate that the joint has gone backwards. All right. And so it would open up. If it had gone forward, you'd have a posterior wedge. So you could have an anterior wedge. Again, if you can see the anterior margin, just stop, because you don't need to do all of this stuff, and this other stuff can mislead you. But if you can't and you really need an answer, now you've got two points of comparison. Unfortunately, those two are disagreeing with each other, right? The posterior margin of C2 is slightly anterior to C3, and we've got an which would indicate maybe it's gone forward, although it's really, really small. And we've got an anterior open wedge, which would indicate that maybe it's gone backwards. All right, what else can we look at? Well, we can come in and look at the parasagittal George's line. And sometimes, and this is going to depend on the angle of the joint. I mean, if the angle of the joint is fairly flat and it goes forward, a lot of the motion of C2 on C3 is going to be forward at that joint. So you're more likely to see a change in the posterior parasagittal George's line, where it's gone forward in comparison to C3, because it's gone this way. But if it's like this, you might not see much change there at all. It's not easily discernible. So again, we don't know, but this looks fairly even, fairly straight. And the last thing you can do is, well, there's a couple of others, especially at the C2, C3 joint, is you can actually look and see. All right, I'm going to have to manipulate this. We got this a little bit twisty, but let's see, we're over here. We can look at the spacing between C1 and C2 on each side, and if atlas or axis has gone forward on C3 on the right, then it's possible that this will look smaller than this one because it's gotten pushed up into it, and so it's squished. I haven't seen that very often, frankly, but that's one thing that you can look at. The next thing that you can do is you can look at the wedging of the disc. So if the right side has gone forward, you might see a right wedge, open wedge. If it's gone backwards, it'll have squished down on here perhaps, and you might see a left open wedge. So these are all things that you can put together in a list. When I analyze X-rays, I've got a sheet, and it's got all kinds of lines going through there. This, that. I don't necessarily fill everything out, but if I'm trying to figure something out, I've got a spot so I remember all the different things to look at as to what's going on. All right, cool. Dr. Elder Javier, thank you. I got a question. What is your parameter to determine what is a major from the minor, or if you're adjusting both of them, which one do you adjust first? That you will learn when you come take my class at Sherman. So that's a little bit beyond what's going on here, but it is related, and I think we do have time for that. So let's talk just briefly about that. Some doctors will only adjust majors. Dr. Blair, only adjust a major. So we'd only ever adjust one thing at a time. And typically he would be looking at, from what I understand, I never met the man myself, which is a pity, but he would look at the amount of misalignment, 2 millimeters, 3 millimeters, 4 millimeters, or the amount of how it would affect the neural canal. He would do a neural canal study, which is taught in the Blair technique for analyzing children, and it's a different neural canal study than Dr. Blair used. His was simpler, but he would look at the neural canal and see if he could figure out which joint or which segment was impinging on the neural canal the most, front to back, and left to right. And then he would determine that would be the major. So he would kind of use those two things to see what the major was. Typically, and this depends on the patient, if you're going to adjust more than one segment, then you're going to adjust the major last. And the thinking behind that is you're going to, I just noticed I can actually type my answers out, which seems kind of strange, but I suppose it's better for the record. Well, we're recording. The thought is then if you adjust the major first and then go adjust a minor, you might knock the major back out of alignment. Whereas if you adjust the minor first and the major, you're less likely to knock the minor back out of alignment, and at least the major staying in alignment, so the body has a better capability of pulling that minor back into place. So is there evidence behind that? I don't know. That's the thinking behind it. What I have found is that determining which one is the major sometimes is just a matter of adjusting the person and seeing what happens. Now, you're going to want that very first adjustment to be the very best adjustment and hopefully never have to adjust them again. So you're going to want to do a super job doing all the analysis, but sometimes there's things we just don't know. We cannot know. The body is way too complex. The problem is we start thinking we know more than we actually do percentage-wise about the body. But sometimes you're going to have a patient and you're adjusting a C1 and C2, and then you realize they're just not holding very well, and so you decide to adjust the C2 second, and they hold better. So I would call that the major. C2 is probably the major. Majors and minors can also change over time as the body heals up. One thing can, sometimes something that didn't show up in the beginning will suddenly show up. Maybe the majors and the minors, which ones they are, change. So I don't worry too much about which ones are the major or the minor. General rule is the higher up the spine, the more likely it is to be the major. So we typically will adjust from lowest segment to highest segment if you are adjusting more than one segment. It's perfectly valid to adjust only the atlas and only adjust one thing at a time, because you can misalign on both joints. All right, I hope that answered that question. Right, so we need to measure two things I want to do. We've got about 16, 17 minutes left. Two things left to do is to measure the C2, C3 joint and below. So we're going to reset so that everything is back to the ground. I'm going to make this, we're going to go back to 5 millimeters. That should make everything clear, but still fairly small. We're going to change this to mean. Computer. There we go. All right. And let's go find, now I'm not going to reset this to where the skull was because I'm not measuring rotation. All I'm measuring is the angle of the joint to the ground. So let's find one. Here's the left side. Let's scoot down so we get that more in the middle of the screen. Okay, so we would go through, we would analyze these, and we measure them. And I typically do that one at a I measure everything and then analyze everything, or vice versa, just because as soon as you start when you analyze, a lot of times you got to twist things around and then it's harder to measure. So what are we going to do? We're going to measure, we've already got it set. We're going to measure the lower segment. We typically, in the Blair technique, there could be an argument for doing this different than I have, but typically the top one misaligns in relation to the bottom one. So the atlas misaligns in relation to the occiput. So when you're measuring those joints, you're going to measure the occiput, the occipital slope angle, the occipital convergence angle. Well, convergence angle is measured off the atlas, but the convexity. But when we're measuring C2 on 3, typically we think and address C2 as having misaligned on C3. So we're going to adjust, we're going to measure C3 because we're going to measure what we are adjusting to. C2 is misaligned. Why would we be measuring that? Okay, now all my lines are level to the ground, so I typically will use a long line for my reference line just so I remember. Sometimes the lines can get really close together. One thing we didn't do earlier that you'll need to have is the almost plane line measurement, but there's several different ways to measure that. So that's not specific to the Blair technique. All right, I got a 43.7 degree there. Now with this particular program, now that I've figured out where flat is for that, I'm just going to cut and paste and move these down. And then come back up here. You'll also notice that after I measured it, I move it away from the joint so I can still see the joint. It's kind of like using plain film x-ray. You don't want to mark on the x-ray right over what you're measuring because then you can't see it later. So same thing here. Yeah, I would take a picture. I would write all these down. And take a picture so that if I ever do decide I need to adjust one of these joints, I don't have to come back to the CT scan and remeasure. Which brings up the point that once you adjust somebody, measurements change. They just don't change usually enough to make that much of a difference. But if you're having a problem, one thing to do is remeasure and see, hey, did their lordosis come back? And so now all the angles are different enough that when I adjust this segment, it's not effective. That's always a possibility. All right, so we would do this for both sides. And then the last thing we would do, and this I usually do last, and it's kind of just to see if there's something that I might have missed, is I'm going to do a neural canal analysis. So what I do, I'm going to line up with the bottommost bone that I can see. Now, typically with cone beams, because they're made currently for the jaw, a lot of times you can't get down really low in the neck because of the patient's shoulders. Now, you get a really thin person, sure, you can see all 7. But you're going to want to see the ear canals and down as far as you can. So in this particular patient, we got 3, 4, C5. This is actually pretty good. He wasn't a small man, so I kind of expected probably to get to C4, but we did actually get all the way down to C5, so that's nice. Now I'm going to put this right in the center of the anterior wall of the neural canal, and we're going to find the peak of this triangle. So this is more accurate than looking at this back here because that can be kind of all twisted away. It's pretty good on here. And look, this blue line's just running right across that back wall. Okay, now I'm going to make sure that we're kind of balanced here, and we're going to go up to the center of the next one. So I'm going to compare this and see if there's any rotation. And if there is a rotation, then I'm going to go look at those facet joints again to see. So let's run up about here. Doesn't look like any rotation. There's some lateral translation because of his head tilt or his neck inclination to the right. So if I move that back over, now it's in the center. There's no rotation. This is still square here. We're still going through the center here. Let's go up another one. So I'm thinking, okay, if there is a misalignment here, it might be a double misalignment forward or a double misalignment back. It's probably not one side or both sides going in opposite directions. So there's no twist. So this is, again, this is not really part of the Blair technique, except that it's maybe a better way to look at a neural canal analysis, which Dr. Blair did. It's just not taught as routine, except in checking x-raying children in the Blair technique. Looks pretty good, pretty level. Let's go up to from between C2 and C3. We're still looking pretty good here. This is maybe a little off. All right, let's bring that up. Okay, maybe a slight rotation. It looks like there was a little bit of translation. It does look like looks like the peak is off to the right, and the peak of the anterior body is off to the left, and the wall of the anterior is a little bit rotated towards the left or counterclockwise. So has the right side gone anterior or the left side gone posterior? Now we looked at one of the sides. I don't remember off the top of my head which one it was, and we determined it was even. So maybe the right side, I think that was the left side. So we're thinking maybe the right side has gone anterior and I just didn't catch it. So let's go over here. Looks pretty good. Oops. Now, I think this back here looks like it's gone anterior, but if you look at the anterior margin, it's not clear. So I would not adjust based on this. Now, if I ran some tests, the leg tests and the, thermography and everything else and determined that C2 was indeed somehow misaligned on C3, then this would be where I would look. But looking at the anterior margin, it almost looks more like it looks pretty even. If I drew a 90-degree line to this, pretty even there. So I'm going to assume that is just an asymmetry on this particular patient. Let's go look at the body. Posterior body looks even. There was a posterior wedge, which would show a posteriority, a slight posterior wedge in the joint. So again, things aren't adding up and giving us a clear picture, and the anterior margin does seem fairly evident that it's pretty level. So I'm going to leave that the same. All right. Any other questions for me? We actually finished about 10 minutes early, so I've got time for more questions. There is always things to go over, advancements that we're trying to make or things that we need to study. Anything that we just study and decide gets added to the Blair technique. There's a process for that. And then we send that out to the profession at large and say, this is, here's a change and why we found it, or maybe sometimes here's a change that was proposed and why we found that it was not accurate. But overall, I would say we didn't really go through and analyze all of the joints. They looked pretty good. And I remember last week when I was looking at this, the only thing that I found misaligned on him was Atlas. And so we adjusted him ASL and saw immediate results by the next day. Now we'll just see if they stay and if I have to adjust them again. Okay. Dina, is there a booklet to describe what you have just reviewed for us? Cookbook style to follow? Yes, the Blair manual. You can get that on the Blair website. It's also, there is a module that is video and things, and that's Jake's module on CBCT analysis, and that goes through using CareStream 3D specifically. He's also got how to analyze things, not just from a Blair perspective, but how to use the cone beam to do an orthogonal analysis. And I believe he may also include the old I say old, but the wedge line analysis that knee, chest, and toggle still use. So that was a good question. Thank you, Dana. All right. Any other questions for me? I'm glad to see you all there. We're doing this again next week. I will publish my February ones relatively soon. I think the week after next, I will be in Sherman. So there'll be 2 Mondays where I won't be doing it. It's probably nice to every once in a while just come back. You don't need to come back all the time, but come back and get a refresher every once in a while once you figured you mastered it. So I'm happy to keep on doing this until nobody's interested. You guys have a great day. I'm going to hang out here just a little bit longer because I got the time. If any more questions come up, I would love to answer them. Okay, I've got 2 more questions. Oh, just thank yous. Morgan, great. Devin, you're welcome. My pleasure. Dina, you're welcome. Maya, I look forward to seeing you in November. Yep. Maya, you're the last one. Never mind. You're gone.